Welcome everyone to the Northern Health Research Conference. It is too bad that we couldn't meet together in person today. I would like to discuss with you the importance of near-peer, upper year, and preceptor-based mentorship for Ontario medical students' overall well-being. Undergraduate medical students experience high levels of stress and suffering in academic and clinical environments that impact overall health and wellness. So much so that some medical students decide to die by suicide. I want you to think about that as we go through this presentation. Stress and suffering have been attributed to debt, witnessing the suffering of patients and peers, long work hours, isolation from family, peers, and loved ones, as well as continuous role and identity confusion in terms of future career paths. This is just scratching the surface. Medical students have higher rates of anxiety, depression, substance use, and suicide relative to the general public and age-matched peers. A relatively recent meta-analysis from 2015 estimated the pooled prevalence of depression or depressive symptoms among resident physicians to be 28.8%, ranging from as low as 20.9% to as high as 43.2%. Jackson and colleagues in 2016 demonstrated that more than half of medical students experienced burnout, leading to reduced workplace productivity, competence, empathy, and professionalism. In conjunction with psychological pressures that contribute to symptoms of anxiety and depression in medical students, their resilience has been found to be lower compared to the general public. Evidence suggests that medical students are also not accessing mental health resources. In a study of medical students from Yale, 33% endorsed not seeking mental health care when feeling mentally unwell. Likewise, another study from 2011 reported that 43% of medical interns screened positive for depression, but only 23% reported receiving treatment. The most cited barriers to accessing mental health resources are time, due to inflexible schedules or very demanding schedules, confidentiality, in terms that if students seek help, they worry it will compromise their future career and end up on their academic performance records, and stigmatization. Unfortunately, fewer than a quarter of medical students with depression actually receive treatment. So, our study aimed to assess perceptions of barriers to accessing mental health care resources among Ontario medical students. We wanted to understand how, 1, medical students perceived the available mental health resources, 2, understand the perceived facilitators and barriers of Ontario medical students accessing mental health care resources, and 3, any strategies, interventions, and/or changes that might aid to overcome the identified barriers that medical students face. For our study methods, we use a purposive sampling method, a form of non-probability sampling, to help ensure selected students provided a balanced set of information regarding their experiences. Study information was sent out by posters, social media, and OMSA listserv. Students must have been 18 years of age or older, enrolled in an Ontario medical school, and passed the perceived stress scale and suicide risk scale. At the time of this research, we interviewed people between May 2019 to March 2020. In total, we have formally completed this research project, hoping to submit to academic medicine, but up to the point of this abstract submission, we had 16 codes completed. We used descriptive thematic analysis to qualitatively assess student experiences. Although not directly the focus of today, because our research applies to all medical students in Ontario, medical students from the majority of schools did discuss some degree of northern/rural related barriers. On your right, we collected demographic information, including the year of study, the medical school, the gender, and any previous resources that students may have accessed. We did not ask or collect personal health information directly, although some students may have disclosed some of this voluntarily. We asked questions in a semi-structured format with some examples on the left, emphasizing questions regarding barriers, achieving and maintaining wellness, and strategies medical students felt would be helpful to overcome identified barriers. Medical students indicated the following barriers: time, confidentiality, and stigma; administrative red tape, such as unrealistic leave of absence policies; overwhelming standards of professionalism, such as feeling unable to go out with friends, feeling they needed to be entirely emotionally detached from patients, and feeling they needed to work more clinical hours than scheduled by institution, since preceptor and school professional values frequently differ, bringing out the infamous hidden curriculum and poor attitudes towards mental health and medical culture. Some geographical concerns included being away from loved ones, traveling and associated costs, and being away from familiar healthcare workers, such as one's primary care physician. Lack of mentorship and guidance from near peer, upper year students, and preceptors was another identified barrier in terms of not discussing life balance, career guidance, and disclosures of mental health challenges. Notably, medical students indicated that mentorship was a standout protective factor for medical students' well-being, particularly when preceptors discussed their own life balance, career path, and importantly, their mental health challenges. So, what do we think? Medical schools in other jurisdictions have indicated similar barriers to what we have found. Particularly, medical students experience felt stigma or internal self-stigma, despite describing subjective decreases in enacted stigma or discrimination by their peers or preceptors against them trying to access resources and disclosures of mental health issues. Medical students also felt that the medical culture in Canada was not conducive to respecting evidence-based medical education wellness strategies regarding workload policies. As much as I would love to continue discussing these, I want to talk more about mentorship. Mentorship is a well-known wellness-promoting factor. Ontario medical students have identified mentorship to promote health-seeking behaviors and overall well-being. Students in our study generally appreciated and respected upper-year students and preceptors who shared personal mental health challenges, finding leadership they could identify with. Evidence supports the utility of medical student mentorship. Near-peer and preceptor-based mentorship programs have reported stress-reducing and morale-building effects in medical students. Many mentees reported resilience building, coping with new situations, and confronting new difficulties with more confidence and professionalism. The USOF study also reported students feeling more accountable to schoolwork, feeling more professional, improving time management, improving self-confidence, improving self-awareness, improving transitions to medical school life, learning tricks of the trade, and making use of new opportunities, and improving their ability to serve as leaders. Interestingly, several studies reported that peer mentors themselves experienced improved reflective thinking, empathy, communication skills, leadership, problem-solving skills as well. Ontario medical students are asking for mentorship. Evidence clearly suggests that mentorship is beneficial for both medical students and mentors in medical school populations. In conclusion, medical institutions should invest in near-peer, upper-year, and preceptor-based mentorship programs for medical students to support their well-being. Medical schools should also enforce evidence-based workload policies to promote student wellness, learning, and reduce rates of serious medical errors in patients. Part 2 of our study will include a province-wide survey to help identify barriers and strategies that students find helpful in promoting their well-being and access to wellness resources. Thank you for listening, and please take good care for now.